Welcome to Everything Optometry and to this clinical masterclass explainer. Today, we're going to turn you into a full-on clinical super sleuth. Whether you're an optometry student cramming for exams, a pre-reg, or a seasoned clinician brushing up on systemic disease, you are absolutely in the right place. We're going to master the art of assessing headache patients, zeroing in on those dangerous red flags, and making life-saving referral decisions.
So, picture this. A patient sits in your chair and casually mentions, I've been getting a lot of headaches lately. Now, as an optometrist, you're often the very first healthcare professional they see. So we have to ask ourselves the most crucial question right off the bat. Does this patient just need a slightly tweaked prescription, or is something much more sinister hiding behind their eyes? I mean, is that headache just simple eye strain, or could it literally be the first warning sign of a life-threatening brain lesion? How do you actually tell the difference? Well, by the end of this explainer, you'll know exactly how.
Here's our detective's roadmap for today. We'll cover the headache detective, spotting sinister signs, essential examinations, visual fields, the papilledema reveal, and finally traffic light referrals. Let's get to it.
Section 1, the headache detective. Okay, so here's a massive clinical tip. In practice, most of your headache diagnoses are going to come straight from your history taking. Once we've ruled out the immediate red flags, which we'll definitely get to in a minute, you want to follow the MIPCA guidelines to structure your investigation. Step 1, ask about the impact on their daily activities. Is it low, or is it really holding them back? Step 2, count the days. You need to ask exactly how many days a month they suffer from this headache. Is it over 15 days or under? And step 3, check for medication overuse. Are they popping painkillers 2 or more days every single week? By asking these questions systematically, you can expertly branch your diagnosis toward either episodic conditions or chronic daily issues.
You really have to listen to your patients closely here, because their phrasing often just hands you the diagnosis on a silver platter. If they say something like, well, I get occasional headaches, but they don't bother me much, that low impact heavily points to an episodic tension type headache. It's kind of like someone tightening a belt around their head. But if they're complaining of absolute misery more than 15 times a month, then you're looking at a chronic daily headache.
Moving on to Section 2, spotting sinister signs. So while most headaches are totally benign, we have to actively hunt for the dangerous, life-threatening red flags. This right here is your danger checklist, and you absolutely need to memorize it. Was the headache a sudden, acute thunderclap? Is it a completely new onset in an older patient? Do the headaches actually get worse when they lie down or wake up? Because that strongly points to raised intracranial pressure. What about jaw ache in a patient over 50? That is a massive red flag for temporal arteritis. Any vomiting or non-resolving neurological deficits? If any of these apply, you are officially out of routine territory.
Which brings us to the golden rule of optometry. If a patient presents with a headache combined with blurred vision, visual field testing is absolutely non-negotiable. You simply cannot skip it. As our sources explicitly state, doing a visual field test might literally be the only way you detect a serious brain disease before it's too late.
All right, Section 3, essential examinations.
Let's open up our clinical toolkit. Remember, your examination should never just be a random series of steps. Every single test helps you rule in or rule out a dangerous condition. Pain during eye motility testing? That points to an optic neuropathy. Hunting for an RAPD during your pupil checks? Again, that indicates optic neuropathy. But keep in mind, an RAPD won't actually show up if the neuropathy is perfectly symmetrical. And finally, make sure you're checking color vision for any desaturation, which is another huge clue for optic neuropathy.
Section 4, visual fields and pathways.
Let's connect the dots between the eyes and the brain. This is exactly why visual fields are so incredibly vital. Take a physical lesion, like a craniopharyngioma, for example. If it's pressing directly against the optic chiasm, it specifically targets the decussating fibers crossing over from the nasal retina. And because of that exact anatomical location, the tumor perfectly maps to a very specific visual field loss. It's like a giant puzzle coming together.
It's honestly fascinating how we can pinpoint the exact location of brain disease just by looking at a visual field map. If you find a heteronominous hemianopia, meaning the visual field loss is on opposite sides in each eye, kind of like a bitemporal defect, that specifically pinpoints disease right at the optic chiasm. But if you find a homonominous hemianopia where the defect is on the same side in both eyes, you instantly know the issue traces further back into the brain, specifically hitting the optic radiation or the occipital lobe. When a hemianopia defect shows bilateral loss that strictly respects the vertical midline, that is a massive, screaming warning sign of visual pathway disease. Spotting these exact defects in a patient who just came in for a routine headache might literally be the only thing standing between them and an undetected life-threatening brain tumor. Next up, Section 5, the papilledema reveal. This is the systemic emergency that completely flips the entire consultation on its head. Just look at the striking difference here. On the left, we've got a perfectly healthy optic disc with nice, sharp, crisp margins. But on the right, that disc is dangerously swollen. The margins are completely blurred, and the whole disc is elevated and hyperemic. What you're looking at is raised intracranial pressure physically pushing down on the optic nerve sheath. Now, to be a true clinical detective, you've got to look past just general blurriness. Look really closely. Are the crossing blood vessels obscured? Is there venous congestion? Or maybe some fine hemorrhages right adjacent to the disc? If you see any of these signs alongside a headache, nausea, or transient visual obscurations, your patient is in real danger.
Section 6, traffic light referrals.
So we've gathered all our clinical clues, and now it's time to actually take action. This is your ultimate exam-ready traffic light system. As a safe practitioner, you must be able to map every single headache presentation directly to its exact referral urgency. We break these down into immediate, same day, urgent, which usually means within 1 week, and routine, which doesn't have a specified time frame. Getting this categorization right is absolutely crucial.
Let's talk about the absolute highest level of urgency. Red means stop everything you are doing right now. If your clinical findings point to an acute optic neuropathy, or if you have an over 50 patient sitting there with a new headache and jaw ache, which screams temporal arteritis, that demands an immediate, drop everything referral. You do not wait around, you send them straight to emergency medical care to prevent permanent blindness or even worse.
Okay, let's put your new detective skills to the test with a rapid-fire case challenge. Imagine a patient sitting in front of you. They're complaining of a headache. You do your exam, and it reveals a progressive optic neuropathy. Then, you look at the fundus, and you clearly see optic disc swelling. Thinking back to our traffic light system, what exactly is your referral urgency here? If you're thinking same-day referral, you hit the nail right on the head. A headache combined with progressive optic neuropathy and disc swelling, or a headache with transient reduced vision and disc swelling strongly indicates serious brain disease. It demands a same-day referral to a specialist. By acting swiftly and confidently here, you are doing exactly what this profession demands. It's like this quote perfectly captures your job is not just finding headaches, it's finding the dangerous ones. Honestly, anyone can nod along to a headache complaint and just hand over an updated glasses prescription. But that's not why we're here. We aren't just treating eyes. We are actively catching systemic diseases and saving lives.
We've covered the red flags, the visual field defects, and that crucial papilledema reveal. And remember, while the history usually hands you the diagnosis, the red flags change absolutely everything. So the next time a patient casually mentions a headache in your chair, will you be the detective who catches the sinister signs before it's too late? Keep your eyes peeled, stay vigilant, and thank you so much for joining this Everything Optometry Explainer.